Hello everyone, let's begin our lecture on endocrinology in peds. So just a few key concepts to remember when talking about the endocrine system for pediatrics. In children, this system is intact and completely developed, but it is still immature, okay? So children's responses are going to vary as those seen in adults. So think about like the responses maybe being slowed or accelerated depending on the system and the hormone that is involved. Just a real quick review of the endocrine system. Remember that it is regulated by a negative feedback loop. So what this means is you have a gland that secretes a hormone, and this hormone has a target tissue or a target organ, and that organ will then release something that goes back to the original gland that is secreting, and it tells it to turn off the secretion when there is enough. The list below here just gives you some organs that are involved in the endocrine system. Many of those should be familiar. I think your textbook has a few others that are sometimes considered part of the endocrine system, but these are the main ones that are always included. So let's move on to pituitary hormones. A quick overview of what the anterior and posterior pituitary secrete. So remember that your pituitary gland is located at the base of the brain, okay? And your anterior pituitary secretes your growth hormones, your ACTH, TSH, your LH and FSH, and your prolactin, okay? And then the posterior pituitary will secrete ADH, or vasopressin, and oxytocin. So we are mostly going to focus on the anterior pituitary here, primarily on growth hormone in this lecture. So when we talk about disorders of the pituitary function, it can really have a variety of effects on the body, including mood, behavior, and physical health. The pituitary gland can be called the master gland because it does have a lot of responsibilities. It also helps to regulate other glands, okay? And as I mentioned before, we have the anterior and the posterior, and they do different things. One of the main things that we're going to focus on is growth hormone deficiency, as I said, and like the name suggests, it stunts somatic growth, okay? So this is normally associated with an anterior pituitary deficiency, and the definition of growth failure is, ready for this, the absolute height of less than -2 standard deviations for age, or a linear growth velocity of less than 1 standard deviation for age, okay? It's a lot, a lot of words, but basically we're going to be measuring these kids, and if it seems like they're falling off their growth curve, this is something that we consider. We will do a workup to make sure that there aren't any other pituitary function abnormalities, so making sure that the other hormones that are secreted by the pituitary gland are functioning appropriately. We'll be screening for things like panhypopituitarianism and other things like that. But most often, these patients will just have idiopathic short stature. Okay, diagnostics that we can also utilize will include imaging of the hands and wrists to determine bone age. They can also do an MRI to rule out any pituitary lesions. And then we can also do some blood tests to look at things like growth factor levels. So we do have 3 different categories for idiopathic short stature. One is familiar short stature, so family members, history of family members being small. We'll be looking at what is called mid-parental height. So we will take mom's height and we will take dad's height, and then that middle height between them would be kind of where we expect that kid to fall. So for example, I'm 5'1", my husband is 5'9", 5'8". So we would expect, our kids to be like 5'5", right? That would be the average adult height that we would be considering. We also have constitutional delay of growth or puberty, which would be something caused by another issue, a different body system or something else going on. And then there's always the unidentified cause, right? We don't know why they're having a growth hormone deficiency, but it is there. So in regards to therapeutic management for growth hormone deficiency, this is still kind of controversial, and you'll find that most things in endocrine are. It's still really debated about which patients should receive growth hormone injections, what is the dose, when do you start, when do you stop, but the current thought is what we're really going to be focusing on. Typically, these patients will grow normally during that first year of life, and then we will start to see that slowed growth curve. The height is going to be what is more stunted rather than the weight, because most of these patients are well nourished, right? So they're going to sometimes look a little bit overweight or obese when looking at their BMI because the height is stunted, but their weight gain is not. And again, just keep in mind that most children with delayed growth or short stature actually don't have hypopituitary dysfunction, but we definitely need to look into that first so that we can treat it if it's there. So the treatment would be biosynthetic growth hormone injections. Okay, these are sub-Q injections that they give daily in the evening. And once this therapy is started, you will see probably most of that growth within that first year after therapy, and then it will slow a little bit, but they will continue until bone age. So by the look, like via x-ray, and around 14 years for girls or 16 years to boys is usually at that point where the bones stop growing. Those growth plates will close, and then they can stop the therapy. If they do have other pituitary dysfunction as well, they may need other hormone replacements, like thyroid extract or cortisone or testosterone, estrogens, progesterones, to treat those other issues. So nurses are obviously key in establishing this diagnosis, right? Because when kids come into the office, who's doing their weights, right? The nurse or the CMA. And if they're seeing a discrepancy, then the nurse is going to come in and do the re-weights and the reassessments. So your accurate measurements of height and weight are really important. Another responsibility would be to maybe draw attention to the provider if the height or weight curve looks off when you're entering the data. The providers are going to have other things that they're looking at, and you're part of that team. So making sure that you're pointing out things that stand out to you could sometimes help avoid something slipping through the cracks. You also are going to be talking to those parents a lot about growth, right? Because height and weight is something that parents obsess about, okay? I still have a height chart in my kitchen where I am measuring my kids every year or every few months, depending. This last time it was to make sure they were tall enough to go on the roller coasters at Six Flags. So it doesn't really end. So as a nurse, you're going to be answering a lot of questions about growth over the years, and also asking the parents questions about their growth. Other responsibilities will include explaining diagnostic tests and helping prepare the families for those, and then doing any teaching if treatment is going to be done for that child. So obviously, starting on growth hormone is a big step for families to take. It can be really emotional and difficult because they're going to have to commit to these daily injections. So you're going to be preparing the parents to prepare the child, right? And also preparing the child, guiding them on sort of what language to use, how to distract that child, and provide atraumatic care while doing these injections, because there will be a lot of resistance at first. And again, we're going to counsel those parents to give them a bedtime. Growth hormone replacement is also really expensive, okay? Depending on their insurance coverage and their financial resources, it might not even be an option. It's important to note that it's about $20,000 a year, and this is, till the kids are 14 to 16 years old. So this is not a short-term treatment, and it can be inaccessible for some families. Okay, moving on to precocious puberty. Okay, this has gotten a lot more attention in the last several years, probably like in the last decade or so. We're seeing children experience puberty at earlier and earlier ages. So there's been a lot of research and discussion as to the why and the what. We're just going to talk about how we define it, what those different types are, okay, why it typically will happen, and some of the management for that. So precocious puberty is defined as sexual development before 9 years of age in boys or 8 years of age in girls, and this is always different because boys tend to go through puberty later. So they have a little bit longer before we call it precocious. This does tend to be more common in girls, however. So we have two different types of precocious puberty. The first is central precocious puberty, and this is about 80% of your cases. So definitely the most common, and this is where you see early maturation of the development of your gonads, which then creates and causes the secondary sex characteristics. So there's a central cause. Peripheral precocious puberty just means that there's premature development of breast, pubic, and axillary hair, as well as menses, but the gonads don't actually mature early. So you just have this peripheral or outer precocious puberty. They will usually screen this with LH and FSH levels, and that's for girls usually, and then for boys they'll use serum testosterone that can help to identify this. As far as management goes, we're going to treat the specific cause, okay? So if we have an issue with adrenal glands or the pituitary gland or the gonads, there would be treatment to manage that first. Sometimes it's actually treated with Leuprolide or Lupron, which is a medication that will slow pubertal growth to normal rates, and then you just stop it at the age that you want those changes to accelerate, so around their normal age of puberty. This diagnosis, as with the other, does require a lot of psychological support for the family, because it can be really distressing to have a 6 or 7 year old girl start to have breast buds or maybe start a period. When they're not developmentally or cognitively ready, this can be really hard. The family wasn't expecting it, so they might be unprepared. One really big thing to remember here is that we want to dress and treat the child like their chronological and developmental age and not what Tanner stage they are, because sometimes these children can appear older and we still really need to treat them at their chronological age appropriately. So let's quickly move on to thyroid and do a quick review here. So your thyroid excretes your TSH, your free T4, your T3, okay? So there's a couple different disorders associated with thyroid that have to do with hyper or hypo, okay? So hypothyroidism can be congenital or acquired. We talk about acquired hypothyroidism in adults a lot. Then there's Hashimoto's thyroiditis, hyperthyroidism or Graves' disease, which is what we're going to be focusing on here. And there's some symptoms down there, but we'll talk about that a little more. And then the treatment for it, which we'll go into more detail in a second as well. So Graves' disease or hyperthyroidism is the most common cause of hyperthyroidism in children. It is believed to be caused by serum thyroid stimulating immunoglobulin, but we have no specific etiology. We don't exactly know why it does this. It causes an enlarged thyroid gland and exophthalmos, which are those enlarged eyes that look kind of protruding and buggy. The peak incidence of hyperthyroidism is between 12 to 14 years of age, but we do see it in infants. So there's definitely a familial association here. If there's a family history, you are more likely to see it in the children. So symptoms, okay, you're going to see that exophthalmos with the eyes, okay. Most of these symptoms are really going to be sort of in line with the hyperactivity, okay. So in the GI system, you're going to see more diarrhea or more GI upset. Cardiac manifestations will be rapid bounding pulses during sleep. They could have a widened pulse pressure. Systolic murmurs can be common, cardiomegaly. Respiratory symptoms will be things like dyspnea with even just slight exertion that normally wouldn't cause an issue in somebody else. Your skin will be warm and flushed and moist. These patients are very intolerant to heat, so they could have excessive or easily triggered diaphoresis, okay? Another thing that you might see is like excessive motion or irritability, hyperactivity, short attention spans. What does this sound like? It sounds kind of like ADHD, right? And so interestingly enough, when we are looking at a child who's being consulted for potential ADHD, sometimes we actually want to look at other symptoms that might be around and see if maybe there is hyperthyroidism that is causing a lot of these symptoms rather than ADHD. So Graves' disease management is basically we're going to diagnose it based on those increased levels of T4 and T3 with a very low TSH or your thyroid stimulating hormone. And so again, therapy can be controversial, but we want to slow that rate of the hormone secretion. So we could do that either through medications or we could do a subtotal thyroidectomy, but if we do that, then they're going to be on thyroid medication for the rest of their life because we're going to create hypothyroidism artificially. Or we could do an ablation with radioiodine, which obviously has its own implications in pediatrics, and there's more information on that in your textbook. So this just is an image of hyperthyroidism for those visual learners out there to help you retain some of the symptoms if you kind of like looking at pictures, and you can take a look at that on your own. And then this is a little baby with hyperthyroidism, and you can see the eyes there and then the reddish skin, and it also looks like mom might also have some. You can see some of her features are a little bit similar there, so this kind of reinforces that familial tendency. So I just thought a visual would be good. And then for nursing care of thyroid issues, obviously we need to identify patients with it. Being alert to those subtle signs, helping the family cope with the emotional lability of the child, okay, and giving them some resources for that. Dietary requirements, helping them meet those needs, those increased metabolic rates, and then medications, right? Education on how to give it, when to give it, and the side effects of those treatments, all right? We're just going to stop here, and we will begin the next lecture with the pancreas and complete the rest of the endocrine system.